Morning, folks. Welcome to the webinar this morning. We're just waiting on, I'm just watching the participant numbers there starting to climb. So we are expecting quite a few people here this morning. So hopefully people are just joining as we come in. You're very welcome to this, which is the fourth All-island Obesity Action Forum. And obviously we're conducting this by webinar today. This webinar is hosted by the All-Ireland Obesity Action Forum, supported by Safe Food, the Department of Health and the Public Health Agency. So this morning's session focuses about the whole systems approach to obesity, and Safe Food have pulled this event together. We're looking forward to good attendance this morning. I think there's over 150 people registered for it, so this is fantastic. And thank you for pulling this together in terms of organising and hosting the event. In relation to obesity across the north and south of Ireland, it is a public health priority, as you guys all know better than me. It's become an increasing it's been a priority over the last 2 decades, but even more so whenever we've seen recently there that the evidence is clear that obesity has been a risk factor for severe COVID-19 disease and death as well. Just to kind of contextualize this and bring it a wee bit topical, you know, we're looking in BMJ published some research there recently that in the United States, for example, and this is irrespective of age, you know, having a BMI over 30 increases the risk of being admitted to hospital with COVID-19 by 113%, of being admitted to intensive care by 74%, and of dying by 48%. And Public Health England have showed similar numbers as well for mortality. Risk of death from COVID-19 increasing by 90% in people with a BMI over 40. So, I mean, this has been a priority for a number of decades, but even more so over the last couple of years, we've seen the impact of obesity and increasing, you know, mortality and around COVID-19 as well. So, I mean, we all know there's a lot of factors impacting on obesity, and this webinar will explore those and the interconnections between them. We are looking at whole systems approach, and we'll have keynote presentations from a number of speakers this morning. So first of all, we'll have Dr. Mirjam Heinan from UCD in Dublin. Miriam's going to talk about the launch of the whole systems approach to childhood obesity, a review of the evidence, and something that's very, very important and a high priority within the Public Health Agency as well in terms of our commissioning. Then we'll hear from Greg Stratton in the Department of Health in Ireland, who'll focus on the Sláintecare Healthy Communities programme. Then we'll hear from David Tumilty in the Public Health Agency in Northern Ireland, talking about our approach to exploring whole systems approach to obesity prevention right throughout the context of Ireland. We'll have a break, and then we'll hear from Joanna Caldera in Safe Food, she'll chair the Q&A session, and then we'll hear from Ursula O'Dwyer from the Public Health of Ireland, who'll provide the closing remarks. So folks, look, welcome you all to the webinar this morning. Numbers are climbing very well there, so folks, I'll hand over now, and hope you enjoy the rest of the morning. Thank you.
Good morning, everyone, and I'll be your chair for the morning. So some speakers pre-recorded their presentations, but they are with us to answer your questions during the Q&A session. You can ask questions via the Q&A box at the bottom of your screen, and this feature will be available throughout the session. Everyone's question will be visible and others cannot vote. Please include the presenter's name that you would like the question to be addressed to, and we will try and answer as many as possible. For any technical issues that you may be experiencing, please use the chat box at the bottom of the screen and address questions to panelists only. We encourage you to tweet about the event, and when doing so, please use the hashtag #ObesityForum. Finally, please note that we are recording the session. Some sections will be available online, as will the instructions on how to request the presentations. As Seamus mentioned, our first speaker is Dr. Mirjam Heinan from University College Dublin. For almost a decade, Miriam worked on the topic of childhood obesity, including being one of the lead investigators of the Childhood Obesity Surveillance Initiative in Ireland. She also worked as an assistant professor at University College of Dublin from 2016 to 2020, where she mainly taught on the Masters of Public Health on the topics of health promotion and social epidemiology. Miriam will be presenting on whole systems approaches to child with obesity, a review of the evidence, and this report is now available on our website. We will not be taking questions on the report today, but any queries can be addressed directly to the forum via email. Thank you.
Hello, my name is Mirjam Heinan, and together with a team at University College Dublin and Queen's University Belfast, we worked on a review, the whole systems approach to childhood obesity, a review of the evidence. I'm very excited and honored to be able to launch this report today at this Safe Foods event. And I'm very sorry I can't be there with you live today due to other commitments. But I'm delighted to be able to give you a quick overview of this report through this short recording. And I will share my slides now with you. I first want to start with explaining what the whole systems approach is. Although there is no single definition, a whole systems approach can be defined as identifying the various components of a system and assessing the nature of the links and relationships between each of them. It is a way of thinking about complex problems. And one of these complex problems in public health these days is, of course, tackling childhood obesity. We have to recognize and deal with all the complexities, interactions, and multiple layers that contribute to a child's health in a wider family, social, environmental, and cultural environment. Systems thinking aims to map all these factors with the ultimate goal to identify potential targets for interventions. An example of this is the Foresight Obesity Systems Map as displayed here. I'm sure the next speaker, Professor Harry Rutter, will go into more detail to explain the whole systems approach further. But what did we do? We did a literature review on the efficacy of whole systems approach to childhood obesity and considered whether this could work on the island of Ireland. And what did we find? We conducted a rapid literature review and identified 14 articles. These articles show different levels of effects on reducing factors that are related to childhood obesity and hence helping in trying to reduce obesity in children. With 3 articles finding positive results, with 7 finding mixed results, so either positive or negative, 3 finding negative results, and 1 study still needs to come out with the results. There are also several criteria that came out of the literature that are very important to improve the chance of success of a whole systems approach. First of all, strong leadership and full engagement of all partners is an absolute key for success. Engaging the local community is also an important component. Creating successful outcomes requires time to build relationships, trust, and community capacity, factors again which are all very important. Good governance and shared values will result in more participation and intersectorial action. Appropriate partnerships are important to create sustainable multi-level environmental change, and consistency in language across organizations to help to deal with differences in organizational beliefs and organizational structures. Embedding initiatives within a broader policy context as it helps to integrate and align initiatives. Also, local evaluations of local interventions is important to inform the effectiveness of local level interventions. And finally, and hugely important, sufficient financial support and resources are a key for success. If used on the island of Ireland, the whole systems approach would need to be adapted to the local context considering these factors. But global evidence shows that there is a potential for whole systems approach to work on the island of Ireland and could make a difference to the quality of life and health of the population on the island. This was just a very quick overview of our findings in our report. And finally, I would like to acknowledge and thank the rest of the team that have made this report possible, with Cale Lawler, who has done the bulk of the work on this report, and my other two colleagues at Queen's University Belfast, Laura McGowan and Roisin O'Neill. Thank you very much for your attention.
And our third speaker now is Mr. Greg Stratton. Greg is an assistant principal officer in the Health and Wellbeing Unit of the Department of Health in Ireland. Before joining the civil service, he was the CEO of TROR and previously the CEO of the Spirit and Asylum Services Initiative. He was a member of the working group that reviewed the protection process for asylum seekers, which formulated the McMahon report. Greg holds a master's in healthcare leadership and an honors degree in public and development management from the University of Stellenbosch. Greg will be presenting today on the recently launched Sláintecare Healthy Communities program. Over to you, Greg.
Thanks very much, Joanna, and thank you very much for inviting me today to talk about the Sláintecare Healthy Communities program. I'm just going to try and get my slides up. Okay, and I hope everybody can see that. It was fascinating to hear Professor Rutter before me, and I'm hoping that I'm going to be able to keep within my time as well as answer some of that stuff. So the Sláintecare Healthy Communities program is an initiative from Sláintecare and Healthy Ireland in the Department of Health. The goal of the Healthy Communities program is to improve the long-term health and well-being of people living in the most disadvantaged communities in the Republic of Ireland. This is a new cross-government initiative. We have funding of €13 million from the Department of Health, and we're working in partnership with the HSE, local authorities, local communities, statutory, voluntary and community groups to deliver the program. In this presentation, I'm going to briefly outline the main concepts, aims and structure of the program. And just to say, we've consulted on the design of this with multiple stakeholders, including government departments across the sector and the local authority and community and voluntary sectors on its design. And just to say from the outset that whilst we're looking at health inequalities, obesity is obviously one of the key risk factors of ill health and mortality in our deprived communities. So most of you are most likely aware of the vision of Healthy Ireland. So we want to create a healthy Ireland where everyone can enjoy physical and mental health and well-being to their full potential.
Sorry, Greg. Greg, yeah. Sorry to interrupt there. We're seeing your presentation inside. I don't know if you can bring it into the full screen so that we can see each slide. You might be seeing it in a different way than we are.
I am indeed, obviously. Let me just see. I don't know what I need to do.
Yeah, you see at the very top there where it says slideshow, and so it's file, home, and then the very top of the grey. It's hard to see now. Do you see at the very top file, home, all of those options?
I am so sorry. I am obviously not very good at this.
Don't worry.
Greg, the way I did it was when I wanted to share screen,
yes.
You have to look around, and there are two. You'll find a number of windows available, one of which shows your full screen slides and one of which shows this view.
Okay.
Now
does that work?
You're a third of the way there. You're 2/3 of the way there.
There?
No, it's a different
screen
still.
Oh, bloody hell.
Oh, it's transcribing you.
Oh, God. I am so sorry. I should have obviously practiced doing this.
Greg, don't worry. Would you like me to share your slides and you can just tell me when to click on?
Yeah, that'll do. My sincere apologies to the 116 people who are suffering through this. And on to slide 2, please. Okay, so just to say that there are 2 goals of the framework which are really relevant to this. So first of all, to reduce health inequalities and create an environment where every individual and sector of society can play their part. Just wanted to also say that we know from the evidence that health and well-being for everyone sort of will be achieved or can be achieved both by population level interventions, and Professor Rutter went into that. But we also think that needs to be done in tandem with targeted interventions for our hardest to reach communities. And the next slide. In terms of the wider context, the current programme for government in the Republic gives a clear intention to address cross-sectoral inequality. It includes a range of initiatives aimed at improving health and well-being across various sectors of government, including education, housing, transport and health. And the Sláintecare Healthy Communities programme also delivers on the Department of Health's statement of strategy, commitment to prevent illness and support people to live healthier lives, and the delivery of a cross-cutting initiative that addresses health inequalities. It is also a priority in the new Sláintecare implementation strategy and action plan, and is central to the new theme on health inequalities contained in the new Healthy Ireland strategic action plan. So there's a significant policy level commitment to addressing health inequality that is supported at the highest levels of government, and it's a significant policy level shift towards addressing health inequalities. Next slide, please. So what do we mean when we're talking about health inequalities? We're talking about avoidable, unfair and systemic differences in health between different groups of people, involving differences in health status, access to care, quality and experience of care, behavioural risks to health, and the wider determinants of health as well. We recently asked the Central Statistics Office to look at standardised death rates by decile of population from the least to most deprived, taken from the 2016 census and applied to deaths recorded in 2017. And what we found was that the standardised death rate, which is the death rate of population adjusted to a standard age distribution, in our least deprived communities was 451 per 100,000 of population. And this was 878 per 100,000 population in our most deprived communities. So there's a significant gap between these deciles. And next slide, please. In our own Healthy Ireland survey conducted in 2017, we saw that behavioural risks to health are markedly higher in our most deprived communities. Similarly, and that applied to levels of smoking, binge drinking and obesity in those areas. There was significant sort of risk clusters and a difference in self-reported health. So we found in the 65 to 74 age cohort, where only 57% of men reported good or very good health in deprived areas, in contrast to 91% in affluent. So there's a very significant difference in self-reported health. And the next slide. So we know that health is created and lived by people within the settings of their everyday life. So where they work, learn and play and all that kind of stuff. The social determinants of health is underpinned or has underpinned the approach taken by Healthy Ireland. And these are the range of factors that impact on health and well-being and are not usually the direct causes of illness, but the causes of the causes. The Sláintecare Healthy Communities programme, if I can take the next slide, is taking a place-based approach to tackling these inequalities. So to effectively reduce health inequalities, we think it's important to start with a conceptual framework such as the Labonte model, which I have up here, which has been adopted by Public Health England and which we have considered in the design of the programme for the healthy communities. It highlights why interventions must focus on treating place and not just people. This is because by acting only on one factor, we're only likely to provide a partial and incomplete response to the situation. We know that health inequalities stem from variations in the wider determinants of health and the presence of or access to psychosocial mediating and protective factors. This means that people do not have the same opportunities to be healthy. Given the range of causes, a joined up place-based approach is necessary to tackle this complex causal pathway of health inequalities. We also know that interventions that solely rely on individual behavior change are likely to widen inequalities on a population level, and given the complex causal pathway impacting on capability, opportunity, and motivation to change. Next slide. So the aim of the Healthy Communities program is to ensure that people residing in our least advantaged communities live longer and healthier lives. We have 4 main goals to the program. Firstly, we want to deliver evidence-based interventions in these selected communities that will prevent non-communicable diseases. Secondly, we want to know, or we know that we need a collaborative and joined up approach where we work together with existing service providers and across government. Thirdly, it's vital that the identified communities are the essential partners in the program and that they have ownership of it, so that we can't just come in with without ensuring that they're enabled and that they have agency within it. And finally, we want to integrate a policy learning cycle into the process. And I think Professor Rutter's presentation, I think, touched on that need to have the policy level interventions, and we want to try and ensure that there's a join between what happens at local level to the policy level. And that was one of the things that we picked up with our consultations with local authority stakeholders, was that there was often policy barriers to addressing health inequalities that weren't being addressed in previous interventions. We want to have the experience of those communities inform the development of policy. And we envisage that this is going to occur via local implementation teams, of which we hope we will have multiple stakeholders. Next slide. So how did we select the areas to be included in the program? It was a process that was taken by the Health Intelligence Unit and the HSE, who have developed the Health Atlas, which provides health profiles by small area and electoral district level. They applied the Pobble HP deprivation index at these levels to identify the areas with highest deprivation, typically below -10. Given the centrality of SICAP and the reduction of poverty and promoting social inclusion and equality, and the role that is played by SICAP, these areas were aligned with the 51 SICAP lot areas. So SICAP is the Social Inclusion Community Activation Program, which is an existing program for poverty reduction in the state. Finally, we engaged with local authorities to validate the selection of the areas to ensure that they represented actual communities and that the program would be able to be operationalized in these areas, given their knowledge across the various agencies and resources that were active within them. At the conclusion of this process, 19 areas were selected to go forward for phase 1 of the program. And we're in the process of currently identifying areas for phase 2. And we hope to include 51 areas by phase 3. In terms of the broad characteristics of the selected areas, there's a total population of approximately 450,000 people within them. The smallest being 12,000 and the largest 40. The 19 areas span all of the CHO areas of the HSE, with 14 local authorities and 17 local development companies included. They're both in urban and rural areas. Some are concentrated in single geographic areas, some have a hub and spoke type configuration, and others have multiple locations. These areas will incorporate people from a range of backgrounds and with a range of very specific needs, and we'll be taking an inclusion health approach throughout the program. Next slide, please. So at this stage of development, we envisage that the program will be implemented via 4 main mechanisms. Firstly, via the HSE and the broader health services. Given the centrality of health services to health inequalities, it's vital that we address health inequality not only via health promotion, but also via addressing access to services. Secondly, given the area-based approach that has been taken, we'll need to address the wider determinants of health through what we're currently calling a local implementation team. And local partnership, we believe, will be a key aspect of this program. And thirdly, we'll be working across government to align and prioritize services and policy responses in the selected communities. And finally, we want to ensure a robust evaluation of the program and its components from the outset. So not only just the individual components, but also the policy level interventions, as well as whatever happens in between. And including the use of data across the multiple stakeholders that we have involved. Next slide. So the starting point of the program is very much from the HSE, and they've almost concluded recruitment of staff to area-based teams to ensure local areas have access to an enhanced health and well-being program, and a core group of initiatives will be established to support a healthy community. Services will include stop smoking advisors, the We Can Quit program, social prescribing, parenting programs, healthy food made easy, and a rollout across the health services and making every contact count within each of these communities. We've also begun to engage with the local government management agency and the City and County Managers Association. And we've begun recruiting local development officers into each of the 19 areas that have been selected. And we're going to be working in partnership with them to put in place these local structures as well as services. So we're keenly aware, next slide, please. So we're keenly aware that there are a multitude of existing programs and agencies that are implementing services within these areas. So we've begun a process to identify these across government, and we'll be creating detailed community profiles to enable targeting of services and support specific to the context of each area. In each area, a local implementation team will be facilitated by the local development officer, which we're currently recruiting, which will address the wider determinants of health at this level with multiple organizations. So we're looking to work across the system. The next slide, please. This organization diagram shows what we're currently thinking will be the structure of the program, we're constantly looking to adjust design as we're proceeding. So the local implementation team will be facilitated by the local development officer, who reports to a national development officer. Information from the local implementation teams will be collated and will inform discussions of the national implementation group, which will have representatives from across government and potentially with representatives from key national stakeholders, such as unions, the ILDN, the Irish Local Development Network, and a range of community and voluntary sector organisations. So this pathway, we believe, will be key in addressing the service provision gaps, the prioritisation of investment from the state into these communities, and creating collaboration and informing policy development. Next slide. We also believe that given the scale and ambition of the programme, that evaluation is going to be central and key. We have established an evaluation working group. And we also believe that the Healthy Ireland Outcomes Framework will be central to determining the success of the programme. The Outcomes Framework was developed with public health experts, and the indicators that have been selected illustrate the areas that will be, or that will form part of the programme implementation. Central to the programme is the creation of positive outcomes for health and well-being within these selected communities. Another critical factor is how that is achieved, and we're also presently considering measures of the impact of collaborative working and driving change. We are highly aware that the change of these outcomes will occur over the long term, and that this consideration needs to be taken into account when evaluating the success of the programme. We'll be looking to build an evidence base of what works with all of the partners of the programme. We want to ensure that a robust policy learning cycle is at the centre of it. We've also been working with the Health Research Board for an evidence synthesis, and we'll be conducting a rapid realist review with them. And next slide, please. Just to say thank you very much again for allowing me to talk about the programme today. I believe that the Sláintecare Healthy Communities programme gives us a unique opportunity to make a real difference to the health and well-being of those most in need in Ireland today. And I'd like to thank you all again, and hope to work with you all in the future on it. Thank you.
Greg, thank you so much for your presentation, and I'm so looking forward to see this program on the ground and to collaborate with you guys when possible. Just a note to say that some delegates are experiencing issues with the Q&A box. You can actually submit questions via the chat, or you could email us at obesityforum@safefood.net. And we can compile your questions then, okay? So our final speaker this morning is Mr. David Tumilty. David qualified in 2004 with a master's in health promotion and is currently employed by the Public Health Agency in Northern Ireland as a health improvement manager with joint regional responsibility across Northern Ireland for obesity prevention. David's experience spans 18 years across various topics and settings, developing and coordinating health improvement initiatives around physical activity, obesity prevention, tobacco control, mental health promotion, and suicide prevention, both on the community sector and across the statutory sector. David has worked towards improving health and reducing inequalities throughout his working career, and today we're presenting on the overarching goals of the Public Health Agency's obesity prevention work. Structures and systems to prevent obesity will be the main focus of his presentation. Over to you, David.
Thank you very much, Joanna. I'll just put my slide deck up. Hopefully I can get it to share okay. Can I just check everyone can see that, or if there's no noise, I'll assume that's all okay.
Yep, all good.
Great. So good morning, everyone, and thank you, Joanna, for the very kind introduction, and for also the invitation to present today. We've had some fantastic presentations so far. I'm sure everybody's quite enthused in terms of the agenda as well. So today what I'm going to do is I'm going to provide a brief overview of the health and social care structures, the strategic links and the statistics regarding obesity in Northern Ireland. It's going to be a whistle-stop tour, just considering that not all the audience is from Northern Ireland. I think that's important. And then following that, I'll look at a consideration of implementing a whole systems approach to obesity across Northern Ireland. So let's see. This slide just highlights the health and social care high-level structure to set the context. So what you'll see here, there's two lines which connect the various boxes. One line is in solid format and one is diced, as you can see. The solid lines show accountability from the political into policy, and it also shows the line of accountability down to the bodies that are responsible for implementation of health-related issues. And I think importantly, you can see also the dice line, which provides the relationship between the organisations responsible for commissioning and the services that are delivered through provider systems. And this structure has been in place in terms of integration for many years. So what you'll see on the screen is the Health and Social Care Board and the Public Health Agency, who are arm's length bodies of the Department of Health. And the board is the main commissioner of services. That board is being replaced sometime in 2022 through a newly developing integrated care system that's going to be looking at commissioning services based on a population health approach. And the Public Health Agency has a statutory duty for protecting and improving health and well-being, and also reducing health inequalities. And you'll see there below that the detail in relation to the commissioning detail around where our services are implemented on the ground. So with that in mind, what we'll see here is the number of strategic drivers and influences that impact on our work and what we need to deliver upon. So we'll have programme for government and the draft outcomes framework, which is really important across government, as well as making life better. Making life better is the Northern Ireland Executive's 10-year whole system public health framework that we work to in terms of addressing health and improving health. We also have community planning, and community planning is about working across sectors within communities where change is needed most. And then, of course, the other documents around the screen is about current transformation programs, including Health and Wellbeing 2026, which is all about delivering together, and also systems and not structures. What you'll see on the screen now is a series of strategies and frameworks that are aligned to the area of obesity. They're led across various departments. So it's not just the Department of Health that has a key role to play in relation to the delivery of action around obesity. And you'll see these on the screen. So I'm not going to go through them one by one. and you'll receive the slide deck afterwards to make those connections. But whenever you then look into the strategy linked to the Department of Health, the main strategy, which is a regional framework for the prevention of obesity, 10-year strategy from 2012 to 2022 is a Fitter Future for All. And Fitter Future for All is a cross-sectoral integrated life course framework. And the aim of it is to empower the population of Northern Ireland to make healthy choices, to reduce the level of harm related to overweight and obesity by creating an environment that supports and promotes a physically active lifestyle and also a healthy diet. Just moving on down then into some of the detail around statistics, having given some of the sort of structural overview. What you'll see here is some data and statistics related specifically to the obesity agenda. You could add to this through some data and statistics around active travel as well, for example. And I don't want to spend too much time on this, but you'll see obesity, physical activity and health inequality data here related to obesity. I want to focus in just on the obesity one, that second bullet point, the 65% of adults. These adults are either overweight or obese, and that's a figure that has risen from 62% in 2018-19 in today's time. But what that is it's 9 percentage points away from the Fitter Future for All target. And that target started in 2012 at 59%. So we really should have had it down to 56% according to strategy target. However, we're currently sitting at the moment 9 percentage points away from that. So there's much work to be done, and it's really important to look at ways to do that. So with that in mind, our whole systems approach is a better way for us to look forward based on what we have been doing in the past. What way do we need to take our work forward in the future? In Northern Ireland, we're currently restructuring our implementation group that delivers on actions against the Fitter Future for All, and that group's called the ROPIG, which is the Regional Obesity Prevention Implementation Group. And what we're trying to do is look at the best way to tackle the issue of obesity. That restructuring is happening at the same time as the development of a new obesity prevention strategy, because the current one finishes in 2022. And a key part of the development of the new obesity prevention strategy will be an evidence review of what works, but also a review of the effectiveness of whole systems approaches. So now is a very timely opportunity to consider the whole systems approach. So I'm just going to share a slide now that highlights the different factors that impact our health. Because what we often do is we look at things in isolation. We focus on actions around our own specific agendas, but it's really, really key and essential that we work in collaboration to develop whole systems thinking. And this illustration shows the factors that impact our health from healthcare through to behaviours, the physical environment and socioeconomical factors. We tend to focus more on the health behaviour side of the house. However, there is work going on in the physical environment and also across socioeconomic factors which are wider. I mean, look at the top half of that diagram, 10% physical, 40% socioeconomic. That's 50% of health is impacted by factors which can be traced back to your postcode. So it's really important that we look across the system. And Michael Marmot said back in 2017, what good does it do to treat people and send them back to the conditions that made them sick in the first place? So with that in mind, what I just want to highlight to you now is the structure associated with obesity prevention in Northern Ireland. The Department of Health lead an obesity prevention steering group across 4 tiers of obesity prevention, as you can see on the screen here, highlighted in different colours. Over to the right-hand side, under tier 3 and 4, you have the Regional Obesity Management Service, but you've also got the Health and Social Care Board and the newly developing Integrated Care System, which have a key role and part to play in relation to services across tier 3 and 4. We then have ROPIG. ROPIG is more at the prevention end of the scale, looking at tier 1 and 2. However, there is a grey area in and around tier 2 and 3 that's important to consider, because sometimes things fall between the lines, and it's important that we make sure that the areas of responsibility and the work is looked at collectively and collaboratively across the system. ROPIG has various partners that lead in various actions. Safefood is an example of one of the organisations sitting on ROPIG. They're across all Ireland, and they promote awareness and knowledge of food safety and nutrition on the island of Ireland. And then the Food Standards Agency, as another example, established in 2000 as an independent government department, working to protect public health and also consumers' wider interest in relation to food in England, England, Wales and Northern Ireland. An FSA in Northern Ireland are responsible for devolved matters relating to food safety, standards, nutrition and dietary health. RUPIG then, in relation to the partners that are around the table, lead on an array of regionally developed programs and initiatives, and some local programs as well are in the mix. Things like food in schools, heard Harry talking about the importance of that earlier, but not in isolation, about minimum nutrition standards for the HSE and wider public sector. The early years is important in terms of having early years obesity prevention programs in place, and then on the exercise side of the house, physical activity referral programs, both in terms of prevention and in terms of some treatment and rehabilitation as well. Underneath RUPIG then, there's the newly developing structure that we're currently looking at is considering the development of work streams, and those work streams will look to align themselves to strategy actions, but we will be led by experts in their own right in relation to those areas of work. So you might have work streams, and it's not set in stone yet, around research, around communications, around policy and legislation, around services, etc. Some actions may specifically focus, or work streams may focus on nutrition, some on physical activity. And one of the work streams might even look at a whole systems approach to obesity as a task and finish work stream to get things up and running. We also then have local area partnerships that sit underneath RUPIG, and there's connection and needs to be connection between those. So the Active Belfast Partnership, the Northern Healthy Lifestyles Partnership are two examples. But these partnerships are coterminous with the Health and Social Care Trusts, and also cover localities, including the 11 councils across Northern Ireland. So they're really a good key vehicle in relation to acting as a vehicle to local delivery. So in searching for solutions to obesity, there have been many attempts, and I have to say there's been absolutely fantastic work across Northern Ireland over the years in encouraging behaviour change of individuals suffering from obesity, and policy actions to address obesity as well. However, many of the attempts haven't led to the desired level of change. You've heard me talking about the statistics up front and the direction that's going, but why is this? And one of the reasons may be that many of the efforts have been focused on individuals, on singular aspects of individual behaviour and or environments. And an example of that might be focusing on efforts to increase exercise or focusing on specifically food label information. So it seems that focusing on single issues alone may be ineffective, as individual behaviour is influenced by so many factors, and addressing only some of the factors while ignoring others may simply be insufficient for understanding and alleviating the causes of obesity. With that in mind, in Northern Ireland, what we're planning then is a whole systems approach at a local level in line with local council or local authority areas, by aligning the local area partnerships, the Active Belfast Partnership, the Northern Healthy Lifestyles Partnership, to the vehicle which is community planning for the purposes of collaborative gain. So there's a couple of steps in this process underneath whole systems approach stage 1, and that's to do a presentation at strategic level to obtain buy-in and support. And once we do that, what we're hoping for is to adapt some early adopters, maybe 2 or 3 local council areas, to become involved in this work and to help look at the process of a whole systems approach to obesity. We'll do that then by working with local area partnerships and the local community planning partnership in step 2. You can just see that on the screen here across the whole systems approach. And what this does in terms of engaging with community planning is influence other system players who are not at RUPIG, but could play a really important and key role locally in relation to the whole system. Moving down then, once we have our early adopters in that local authority area, we'll move to look at working with health intelligence around the data and the importance of evidence, etc., to look at statistics, to look at inequalities, and also to map current programs in the locality areas that are identified as early adopters. We'll then move into our stage 2, and item A of stage 2 is to engage a number of people in the locality areas that have been identified and train them in whole systems approaches, train them in systems dynamic cause and effect relationship, in order for them to take the lead and start to drive some of this work at the local level in line with their local partnership. What that looks like, and I've taken this slide, I know some people have spoken about it before, in today's presentations. Not exactly the same one, but this is a cause and effect map, which was developed back in September 2019 by the Innovation Lab led by Conor Meehan, who generated a systems map on the cause and effect around childhood obesity. And what this just does, and we've talked about it earlier, is it highlights the complexity. So don't expect people to be able to read all this. But the central variable that we're trying to address through cause and effect maps and system dynamics is obesity. And what this will do is it's used really to help us gain and hopefully get an improved perspective on why obesity occurs and what can most effectively be done to alleviate it. And the model essentially then acts as a reference point for all the different factors producing obesity and the relationships between them. And although this seems daunting, and when you get to the local level, it will seem daunting working with those local partners, it's built according to the stakeholders who created it. And it's really important that you bring those guys on board. And some speakers have talked about that earlier today as well. And it really acts and serves as a basis for discussion, but it also acts, and I think this is important, for an opportunity for disagreement with what it says. So it's a tool for dialogue. It's a tool for helping to ground the conversation in clear language in relation to cause and effect. And that's why many have argued that one needs to take a systems approach in order to effectively understand and also alleviate the social issues as complex as obesity. So flicking back down then into the stage 2, we just highlighted this section. So moving down into item B of the second stage is where we adopt then the Public Health England model of developing local area workshops to take us through the different phases associated with their model. So you'll see there phase 1 is about setup and getting buy-in. Phase 2 is about building a local picture. What we will have already done in Northern Ireland by that stage is some of that work, but it's still really important that we do further work on phase 1, and phase 2 to get buy-in at the local level in order to make this work and bring people on that journey with us. Then move into phase 3, looking at cause and effect, looking at the people that have been trained and trying to get them embedded in some of the decisions and some of the workings through in relation to that work. And then moving towards action collaboratively across the system. In Northern Ireland, it's about working together on the process at the moment of a whole systems approach and to consider the local system. It's to learn and discover on the best approach to implementation. And once we have that completed, having obtained senior level buy-in at community planning level and having the structure of ROPIG bought in and signed up to this, it's about looking then to provide the resource, the people and the funds that are required from stakeholders to implement an agreed action plan. What's also important at this stage is you'll see just on the right hand side a wee bit of detail about local and a wee bit of detail about regional. What this is about is, it's essentially about making sure that local whole system approach plans are signed off at the local partnership group. So that's your Active Belfast partnership, your Northern Healthy Lifestyles partnership as an example, but in conjunction with ROPIG, which is your regional body looking at the prevention of obesity across Northern Ireland. And then where there's regional aspects of whole systems approaches that are being fed into the local, it's important that they are fed up through ROPIG for ROPIG to take action at that regional level rather than local systems trying to implement change, which they can't. ROPIG have the opportunity to affect that change, and where ROPIG can't, to feed that through to the next stage in the chain, which would be, for example, the obesity prevention steering group led by a department. So if there's requirements to change something to do with policy or legislation, for example, it would be fed up through the regional group and up through OPSG accordingly. Just going to highlight a slide on the screen now, but I'm not going to talk to it, which is just a diagram of the Public Health England whole systems approach to obesity. It's in the slide deck for people who want to have a look at it post event. But what might this look like in Northern Ireland? And this is very much a might at this stage. I've just put some indicative timings on this. So you'll see at the bottom, towards the bottom half of the screen, that in rectangular boxes in yellow, orange, green and blue, I've kind of highlighted the phases that are associated with the Public Health England model. And if you look at the arrows then, in terms of time frame, in February 2022, we're going to look for the early adopters. March 2022, statistics and mapping, as well as providing training, bringing in experts from the field in relation to provision of that. April to June 2022 is looking at some systems thinking and causal maps at local area levels with those early adopters. and then moving through into July, October 2022, some local area workshops, and there'll be a number of those where focus groups discussions will take place at various points in order to consider whole systems approaches in their totality and work towards then action planning. And that could take some time based on some of the conversations I've had with colleagues across the UK. It can take upwards of 18 months. But we're going to do what we can. I think evaluation is also key within this section in terms of consideration. So there's lots to do. There's some very exciting times ahead with challenges, I have to say, but it's important that we have the drive and the energy to work together to tackle the issue of obesity as effectively as we can. Thank you. And I've just provided my contact details there for anybody who wishes to get in contact with me post-event.
David, brilliant presentation, and thank you so much for highlighting the strengths of collaboration and partnership. So it's now time for our Q&A session, and I will ask all our speakers to turn on their cameras and their mics. Our colleagues have been gathering the questions, and I may address some of them to one of the speakers, but please feel free to intervene and contribute if you feel like it. I think my first question is, while it wasn't addressed to a specific presenter, it's around the UK program, so I may leave it for Harry and David. It's becoming difficult to discuss obesity without addressing food poverty. Families are struggling to feed families on a very tight budget, and food bank usage is now up. It is time to review the Healthy Start program in the UK, do you think, and to boost family spending on healthy food?
Thanks. I suppose that there are, difficult question. I think the increase, so to take a systems perspective, which is what I'm here to talk about today, I think we need to consider both the short-term response to an urgent problem and the bigger picture, longer-term problem at play here, which is inequality, deprivation, food poverty in general, a broken food system, broken unsustainable food system, and the multiple things that need to be done to reshape food systems to support health, environmental sustainability, and equity. So over the medium to long term, sure, of course, we need targeted initiatives to promote healthy foods and many other things in particularly vulnerable populations, such as the young. And I wouldn't argue against that for a moment, but they need to be part of a package that is actually building a trajectory towards getting rid of food poverty in the first place. Of course, we've got to deal with the urgent problem. Completely support that. I'm not an expert in this field. I don't know what the best approach is to do that. But let's not do that at the expense of actually tackling the fundamental problems here, which are about poverty, deprivation, inequalities, on the back of a really broken food system that is part of, the mess that we've been seeing over the last couple of weeks at COP26.
Thank you, Harry. Thank you so much. I have a question for Greg now. Greg, are there any plans for cross-border pilot programs, or is this solely a Southern approach? Interested in any conversations towards an all-island approach to whole systems?
At this stage, I don't think we have any plans to go, across border. It is solely a Republic of Ireland approach at this stage. don't really have too much more to say to that.
No, perfect. And can you elaborate on how the Healthy Communities program links in with charities that often have been developed to engage with specific communities to provide health promoting activities on the ground? So are there going to be links there with those that were already promoting activities in the community setting?
Yeah, so I think what we're envisaging is that each of the 19 communities, and each community, I think on average is about 24,000 people, that they all have their own specific issues that are driving health inequalities within them. So what we're envisaging is that through the local implementation team, which will be decided locally in terms of its membership, so it might include several charities that are very active within that community, it might not, but that is decided locally in terms and is very much also decided according to maybe the health profile of that particular community, whether it's urban, rural, that it very much needs to depend on that, on the context within it. I think we're trying to get away from trying to take kind of one size fits all approaches to this because of that complex causation that's in play there. So what we're looking to do is through that local implementation team, but also by driving investment towards those particular communities to address the specific drivers and levers that are active within them. That we engage maybe with charities in one context, we might engage more with statutory services in another. But what's really important to us as well is that we're lifting particular issues that might be prevalent across communities to national level sort of consideration. So that might be working with charities on a national level to address specific issues. But what we're trying to do is to be adaptive and to say, well, actually what we need to do is provide stuff that's relevant to particular places and not just, we think this is going to work and go with that.
Thank you. A question for all now. How do we address weight stigma, which has a significant influence on how people participate and engage in health initiatives, especially nowadays with the current media framing of obesity?
Yeah, I'm glad someone raised this. And I also saw there was a comment in the chat from Mara Murphy, as a person who lives with obesity. And I think some of this relates to that language. We should be talking about people who live with obesity, not obese people. We should be very clear that, and this really ties into some of the stuff I was talking about, the focus, the relentless focus on the individual in this is part of the stigma problem. And this is one of the reasons I care so much about the skew in the evidence base, which is hugely driven towards the individual level factors, ignoring the things that drive those individual level factors. And I think we need, if we're going to stigmatize anything in obesity, it needs to be the behavior of corporations that are driving the obesogenic environment and dumping health costs on other people and on society. And we need to be absolutely relentless in our push to avoid stigmatizing individuals. It is a harmful, unkind, unreasonable, and scientifically unjustified thing to do. And I think it needs to be given a much higher priority in all of our work on obesity.
Thank you, Harry. Any other panelists would like to address that? If
not, could I add a second thing? Because it actually,
you can absolutely, Harry.
I just realized it crops up in the chat, and this is the really strong push that I completely understand to push obesity, to frame obesity as a disease. And at one level, I strongly support and endorse that. I understand the basis for it, but I also think it needs to be done in a very nuanced way. So for people living with obesity, obesity can be a disease, but there are the word obesity gets used to mean many, many different things. It gets used as a technical term, it gets used as a stigmatizing term, it means many different things, and some of those meanings of obesity are appropriate when we're talking about obesity as a disease. I don't think we should say that everyone who has a body mass index above 30 has a disease. And I think that the ways in which an unnuanced use of the obesity as a disease argument can actually push, can it support and endorse the individualization of the problem, because it's focusing on an individual with a disease, rather than seeing a different meaning of obesity, which is obesity as a societal problem, very largely, not entirely, but very largely driven by commercial determinants. I think it kind of lets that off the hook, and it medicalizes a problem that is fundamentally social, political, and economic. And so I'm not saying we shouldn't be talking about obesity as a disease, just that we need to do it in a very carefully, well thought through, nuanced way, and be aware of the potential pitfalls to that.
Thank you. Anyone else would like to expand? I can move on to the next question. David, how does the PHA engage and learn from people who live with obesity in Northern Ireland?
Yeah, thanks, Joanna. And it's a good question as well. I think there's different forms and mechanisms, for example, through community planning, where people engage in conversation and dialogue around key aspects of health. This is actually a particular interesting area of conversation, because we have been discussing how do we actually build PPI and service user engagement into our structures in Northern Ireland. So when you look at the diagram I presented on earlier, which was ROPIG, OPSG, BROMS, etc., we've been having dialogue about how do we embed PPI and service user engagement to find out the views and opinions of people that really matter in this agenda. So we're working through that at the moment. But one of the things is, in terms of the sheer number of people who have a voice in this, sometimes those people are condition specific, maybe diabetes or whatever it may be. It's about trying to identify the right people through that mechanism. However, I do also think that whenever we work in relation to a whole systems approach locally, one of the reasons to go local is because you start to get underneath the skin of some of the detail that's required, which is important to people in those communities. So this isn't just about trying to engage with government departments, which is really important for collaborative gain across the system. It's also important to try and embed within that the views and opinions of service users through engagement, to try and find out from them what is important, develop case studies on those people. What are the issues that are actually leading to some of the issues that they're experiencing in terms of obesity? And, you know, it probably touches slightly on the last question and the points that Harry was making, but, you know, we really need to start to increase a better understanding of the issue of obesity. And if we don't do that with service user engagement, I don't think we're going to get very far, because you need to take people on the journey with you. You need to develop those case studies, and you need to show examples of good practice as well as you move forward on it, to really make a difference and make a change.
Thank you, David. We got another question here that emphasizes the need for nutrition expertise and input to all aspects of tackling obesity, and in Northern Ireland, that expertise would be largely employed in the health trusts. How can this expertise be made more available to councils, communities, and charitable organizations and food businesses and producers?
Again, I think this is about, you know, it's interesting again in relation to the comment, because very much true, but how do we actually train other people to become experts in that field? And that's not going to happen overnight. You know, the guys who we have within the Health and Social Care Trust who are leading on nutrition, who have expertise, have qualifications that have taken years to develop. And it's important that we make sure that what we're embedding through training and initiatives is done in a way that we're not actually having a negative impact in relation to the information that's going out there on the ground about nutrition and diet, etc., etc. So it's a good question. It's something that we will need to consider in a bit more detail, but very much agree that it's an important factor in relation to trying to address obesity.
I have a question for all of you, and it's my final question because we are running out of time. And I would like you to stick to maybe a minute each, if possible. What are your thoughts on the industry involvement in combating obesity, particularly reformulation?
Maybe I'll go first. I think I've already made my views on the role of the industry in obesity reasonably clear, but actually it's more sophisticated than that because there is no one industry here. There are many industries at play. And one of the core points, it seems to me, is that there needs to be a principle of internalizing externalities. This applies across public health. So at the moment, the harmful effects of unhealthy food, the harmful effects of fossil fuel powered transport, which includes electric cars, on physical activity. These are borne by society. They're not reflected in the pricing structures that underpin either the food we eat or the things that we do to move around. And by internalizing those harmful externalities, you change the pricing signals and you create a much more level economic playing field that opens up opportunities for the businesses selling healthy products, well, whether that's bicycles, footwear, or broccoli, whatever it might be. And so I think we need not to see industry as a monolith, but I think we need to be extremely cautious about how we engage with industry. Clearly, there is a really important part for many industries to play in dealing with this, but most of the problems we see with obesity are fundamentally driven by misplaced economic priorities, and we should not be getting vested interests to help us address problems that they have helped create.
Thank you, Harry. David?
Yeah, I think we just need to be mindful of conflicts of interest whenever it comes to, you know, some of the work in relation to involving industries in relation to combating obesity, but I'm not too sure. It's important that how do we communicate with them in relation to an understanding of the intended and unintended consequences of what they are doing, to try and highlight, you know, the factors that we're trying to make change against. So I think the conflict of interest is there in terms of their role, our role, but is there an opportunity through the work of whole systems to try and engage through various sectors, some opportunities for discussion and dialogue in relation to those intended stroke unintended consequences? Thank you,
David. Greg?
Yeah, I think there's a balance. So I think, I mean, if we look at the sugar sweetened drinks tax and how what's an industry reacted by reformulation, you know, so I think that there are levers that we can use in terms of how we sort of work with them in terms of reformulation, and yeah, I think it's tricky ethically as well in terms of, you know, and those conflicts of interests are certainly there. So I mean, it's not necessarily part of my brief within the Department of Health, so it's not something I can necessarily comment on a huge amount, but yeah, I think there is a role for everybody to play within the system, and I think it's about how that interaction is managed is the most important part of that.
Thank you, Greg, and thank you to all our speakers. It was a great morning of presentations, a very interesting Q&A session, and I will now hand over to my colleague Ursula Dwyer from the Department of Health. She will provide the closing remarks. Ursula is is a health promotion policy advisor. She works with Healthy Ireland, and she will be providing the closing remarks now. Thank you. Over to you, Ursula.
Thank you very much, Joanna. Now, sorry, just let me focus my screen. Good morning, everyone. It's really interesting morning that we've had, and I'm delighted to be here with you to hear about the whole systems approach to childhood obesity on the island of Ireland. It's great to have the Safe Food report launched now, and to hear from Harry on the broader perspective. And by the way, Harry, I definitely want some of whatever that woman on the bicycle had, if you can find that out, please. So yeah, it was interesting to hear, obviously, about the way, David, up in Northern Ireland, how you guys are moving forward on this. And then you heard from Greg about our very exciting Sláintecare Healthy Communities project. I apologise if you can hear my two little canine helpers in the background. Sometimes they get a little bit frisky, and unfortunately this is one of those times. Anyway, to come back to today. So it's really clear from the presentations this morning that obesity is a complex issue, and that a whole systems approach involving various sectors and systems in society is needed to address this issue. One of the things I would like to mention, because it was a question as well, and that is in relation to the Sláintecare Healthy Communities program, that we actually are also providing the Department of Health are funding the HSE to grant aid the local partnerships, 19 community food and nutrition workers, and that will be one for each area, which Greg has already mentioned in the 19 communities. So I'd like to thank you all for taking the time to tune into this webinar, and a special thanks to our speakers for taking part. And thanks also to everyone who was involved in organising the webinar behind the scenes. We will be emailing you a quick survey on today's event shortly, and we'd be grateful if you could take the time to complete this. And I'd also like to remind you that the presentations will be available online after the event, or can be emailed to you requested from obesityforum@safefood.net. So just to say, as I say, plenty of food for thought this morning, and lots for us to go on, but it's really interesting that the whole systems approach has been seriously considered over the whole island of Ireland, and that starts have already been made to implement this type of an approach. Thank you very much.